then go on to the indications for a removable partial denture. So they talk about replacing several teeth in the same quadrant or the same arc. But I think we've, covered that already, okay? And then from there, temporary replacement for missing teeth in a child. So normally with kids, so that the patient, for example, does not get severe orthodontic problems in the future, and if aesthetics are very important to the patient slash the mother, let's say like your kids who attend like beauty pageants, then we would put like a removable prosthesis in. So one, we are improving this aesthetics, we are stabilizing the arc, and then most importantly, we are maintaining the space where the primary teeth were, let's say for example before extraction, or before an extraction, for example, so that we do not lose that space and cause orthodontic problems like teeth moving in all these other directions. Then from there, we can replace missing teeth for patients who do not want fixed bridge or implants. So there are patients who do not want fixed bridge or implants. Normally, this is because of financial issues. Bridges and implants are quite expensive. So if you give the patient all the treatment options, like, look, you can do dentures, you can do bridges, you can do implants, but this costs like 10,000, this is 2,000, this is 20,000, the choice is very obviously probably going to choose a removable denture. And then it's also for patients who find it easier to maintain a good oral hygiene. So because the prosthesis can come in and out, patients can then actually take it out, maintain it properly, also maintain their oral cavity properly. So it just works out better for everybody. And then as well, to serve as a splint to support periodontically involved teeth. So normally, let's say periodontically involved teeth, where the patient has severe perio and the teeth are very mobile, the denture base, especially for example in the mandible with the mandibular incisors. So these are mandibular incisors, 3 1 3 2 4 1 4 2. So now they're mobile. Then we place the denture in. So it works as a splint to keep them actually from being even more mobile and actually staying in the oral cavity. So we try and save those teeth, and then maybe go through the patient with the patient through perio treatment, so that we can actually maybe try and reduce the severity of the mobility, so that the patient can actually save their teeth at the end of the day. So then the contraindications is a lack of suitable teeth in the arc to support, stabilize, and retain the removable prosthesis. You get a lot of patients who have very carious teeth, or teeth with like dental abscesses, or very mobile teeth, like class 3 mobility type of teeth, and they'll still insist on keeping those teeth. It does not make sense, because they're going to give you issues in the long run. So it's like you wanna put a denture in with problematic teeth that are going to give you problems in the future. So then that would not be suitable for a removable denture. And then from there, rampant caries or severe periodontal conditions that threaten the remaining teeth in the arc. So if the prognosis of the remaining teeth are not good enough, or is quite poor, you would not then want a prosthesis in that mouth. We'll have to first then encourage the patient to sort out those periodontally compromised or severely carious teeth. Normally by that would be like extractions. Advise the patient to first extract, wait for healing, and then we come back to the drawing board in terms of, are we going for removable, or are we going for a more fixed solution? So that's basically what they're talking about, because some patients, like, no one likes losing their teeth, so now they are extra stubborn in terms of trying to maintain those teeth in the oral cavity. Then there's a lack of patient acceptance for aesthetic reasons. A lack of patient acceptance for aesthetic reasons. So I think here they're talking more about patients who are like not compliant, who are poorly motivated, who are not ready, or who feel like, oh, their teeth look fake for whatever reason, or people can tell that I have a denture, or you hear all these funny excuses. So a patient who's really not that cooperative for whatever reason, then you'd rather just leave them alone, or give them reasons, encourage them to go home and think about it, and then they'll usually come back and, I don't know, follow treatment protocol as we had suggested. But at that particular time, when the patient is not willing, not keen, you'd rather just leave them alone, listen to what they're saying, try and encourage them, but leave them for that interim and then encourage them to come back at a later time. And then chronic poor oral hygiene. So if the patient is really not able to maintain their oral cavity, then a removable prosthesis is not for them. Okay, ladies and gentlemen, so removable prosthesis or dentures, ne? So like we mentioned before, it can either be a partial dentures or full dentures. The other type would be, is the denture acrylic or is the denture made out of metal? So acrylic is the normal pink dentures that you guys see with, yes, with the little pink base, ne? And then the metal ones we call chromies. Chromies stand for chrome cobalt. So that is the type of denture that we can also fabricate for patients. So normally they're made out of metal, like I mentioned before, chrome as well as then cobalt. So it's then known as a chrome cobalt denture. So these dentures have lots of little components that make up the entire unit as you see it. They can be very beautiful in design, and they're very lightweight, they're very strong. Normally with the acrylic ones, the plastic ones, one bad fall and it just breaks easily, but it's also easy to repair, whereas your chrome cobalts, the patient can actually drop the denture multiple times before it actually breaks, but it's also more expensive to make, obviously, because it's made out of metal. It is quite lightweight, so that's very nice about it. So it feels lighter in the patient's mouth. It doesn't feel as bulky as the acrylic dentures, né? So those are some of like the advantages and disadvantages of acrylics. For you don't have to necessarily know that, it's just nice to know as part of the lecture. So chrome cobalts are made out of multiple components, as in the denture itself as you see it, ne? So it has the metal framework, connectors, retainers, which are your clasps, the rests, the denture base, as well as teeth. So we're going to delve into those components in 2 seconds. So the first component would then be your framework, ne? So the framework basically is the structure to which all of the components that I just mentioned before are connected, ne? So it brings everything together. And then from there, this framework also normally has like mesh. Okay, so this mesh portion is where the acrylic is going to be placed, onto which then teeth will be retained, ne? So basically the acrylic portion is surrounded by the framework, and the framework is what connects all the components together. Okay, we then have our connectors, ne? So our connectors join the various parts of the partial denture together. So they basically bring everything into a single unit, okay? So we have then 2 types of connectors. We have our major connector as well as our minor connector. So with the major connector, this is a connector that basically connects the one side of the arc with the other side of the arc. So basically with the left side to the right side. So in the mandible, the most common type of major connector would be a lingual bar, né? And then in the palate, it would be then a palatal bar or a palatal strap or a strap. Yeah, that's the word I was looking for. So that's basically with our major connectors. We then have things known as hinges, né? So hinges can also be connected into or form part of our connectors, né? So a hinge basically acts as a what you might call this, a stress breaker. So they distribute stress. Even our connectors, basically, they also then they distribute stress. But the hinges in particular, they help relieve the denture itself in the maxilla or in the mandible of pressure, especially when the patient is undergoing mastication or masticating in their normal daily function. So that's basically the importance of a hinge in the frame of a denture. We then have our minor connectors. So our minor connectors connect our major connectors to the other parts of the framework, particularly our clasps as well as our rests, né? Then from there, minor connectors are important because they prevent food impactions between the tooth and the tissue junction, né? So they fill those spaces so that we do not get food impactions in those particular areas in a patient's oral cavity. And then from there, they maintain the they maintain the integrity of the arc, né, by keeping an anterior posterior bracing motion. So that's how they basically stabilize the arc. So that is basically the function of a minor connector. We then have our retainers, ladies and gentlemen. So retainers are most commonly known as clasps. They support and provide stability to the partial denture by partially encircling an abutment tooth. So in normal man's terms, retainers, or clasps rather, they stop the denture from moving. Okay, so they stop the denture from moving and they keep the denture in position. So that's basically the main function of a clasp. There's two types of clasps. We have our circumferential type clasps as well as our bar clasps. So the circumferential clasps are the ones they're describing here, that they partially encircle an abutment tooth. So they make like a C shape around whichever tooth you have selected as your abutment tooth in the oral cavity. And then from there, a bar type clasp is one that comes from your gingiva, so it moves from a gingival direction towards the occlusal surface. I'm sure a lot of you are wondering, what the hell is an abutment tooth? So an abutment tooth, ladies and gentlemen, is basically a tooth that helps keep a denture in place. Okay, or tooth or teeth that help keep a prosthesis in place. That's basically what an abutment tooth is. So that's why we mentioned before, when we're talking about factors that you have to take into consideration. If teeth normally, so let's say an abutment tooth, you have a situation where the patient does not have their molars, they only have their incisors, canines, and just premolars. So then your 4-5 would be an abutment tooth, or a 3-5, for example, because those are the last teeth that are probably present in the patient's oral cavity. So you're going to use those to anchor your teeth. So now, if for example a patient has periodontically compromised teeth or very mobile teeth, for example, or they're heavily carious, then obviously they can't be used as an anchor sort of to keep a denture in place. We'll have to then look for another option to help keep this denture in place. So we'll have to probably choose another clasp tooth. But that's basically the function of a clasp. It is to keep dental prosthesis in shape, in the same position in the arc. Does that make sense? I hope I didn't lose you guys, but yes. We then move on to rests. So rests in your slides are mentioned as a metal projection designed to control the seating of the prosthesis. So the function of a rest, if I can put it this way, they provide horizontal as well as vertical support to the denture, and then from there they then provide support or maintain the relationship of a denture to its supporting structures, be it the underlying supporting structures or all the supporting structures in the oral cavity. So they maintain the relationship of the denture relative to its supporting structures. And then from there, ladies and gentlemen, rests can be placed on multiple surfaces depending on the patient's oral cavity or dentate state. So rests can be placed either incisally, lingually, as well as on the palatal aspect of a tooth. Normally with the abutment teeth, like I mentioned abutment teeth earlier on, we try and place the rests relative to the long axis of the tooth, so that its function, or rather its forces, can be directed along the long axis of the tooth. Okay, so that's basically what we normally do with rests. So rests, ladies and gentlemen, let's say now we have an abutment tooth. As the dentist, I'm going to prepare, so before we take impressions for the denture, I'm going to prepare a smaller, I don't want to say cavity, but a preparation, we just call it a prep, a little prep on the abutment teeth that is close to the long axis of the tooth, without damaging too much enamel, without exposing the dentine, so that it does not become too sensitive, so that at least when the lab technician makes the denture, then they can actually see the preparation and try to place rests relative to what I have already prepared as the dentist. So basically that's what a rest does. Then, ladies and gentlemen, we have our artificial teeth. So our artificial teeth can be constructed either from acrylic or porcelain. This is the same story, similar to our CAD/CAM examples that we had in last week's lecture. Acrylic or porcelain teeth. So artificial teeth, that's basically what we are trying to replace with this denture. So this would then, our teeth would normally be placed on top of the meshwork or acrylic that is part of the frame. So now here we have our frame, our metal frame, and then on top of our metal frame, you remember our metal frame, I said normally has mesh, where let's say we have lost our teeth. So we have our framework with the little mesh where we're going to place our teeth. Then from there, the technician's going to add a layer of acrylic so that we can seat our teeth. And then on top of the acrylic then would then be our teeth, the teeth that we are actually trying to replace. So then for aesthetic reasons, that's where our shade guides come in. That's where your role as a dental assistant comes in. So we help the patient select an appropriate shade, and then we then construct or select our artificial teeth based on the shade that we selected. Artificial teeth, be it acrylic or porcelain, come in various shapes and sizes, and sometimes you can even fabricate, or the lab can fabricate teeth for you depending on how big the patient's teeth are. So if a patient maybe has very big or very small teeth, they can use or make teeth that actually are in line with whatever is happening in the patient's mouth. So that's that when it comes to artificial teeth. So here, the next slide basically is showing you the maxilla and mandible with chrome cobalts in both the maxilla and the mandible. And then just please try this exercise now that I've explained everything to you. Try and identify where your connectors are, where your framework is, where your acrylic base is, where your teeth are, and everything that we've basically discussed. Try and label these diagrams. They will help you and they're very important. So please do that as a little exercise at home, okay?